Mhm.
All right. Well, hi, everyone. It's Tony Eskander here on behalf of the CDMS. Just really wanted to thank everyone that's been involved in this session. The topic of today's virtual tumor board is current state of management of cutaneous melanoma. Just to introduce the presenting fellows and mentors in combination are Harleen Sethi as the fellow and mentors Joe Curry. We got Dr. Shiel and Dr. TJ Au from Memorial Sloan Kettering. We've got Dr. Towns and Dr. Gupfert from MD Anderson. Our senior discussants are Don Weed from the University of Miami, and we have a fantastic medical oncologist from Albert Einstein, Yvonne Sager. And our moderator, thank you, is Jessica Yasensky. So I'm going to hand it off to Jessica, who will lead the session and discussion for us.
All right. Thank you so much. I have the case from Adam and TJ, and I can share that screen.
I can share the presentation from here.
You can? Okay, thank you.
Can you all see?
Yes.
So this is an interesting case, like Dr. Aw was able to see here in the clinic. It is a 74-year-old female patient that was referred by an outside dermatologist for evaluation of a left vertex scalp lesion. The patient referred that she felt a lump on her scalp since November from last year and denies any other symptoms. So they performed a biopsy and it came out as a melanoma desmoplastic type, no ulcerations, Breslow thickness of 1 millimeter, and Clark level 4, 7 mitotic cells in per square millimeter, and they staged it as a PT1B. There was a Castle genetic testing, which was shown to be as low risk. Past medical history of this patient is anxiety with claustrophobia, bilateral glaucoma, irritable bowel syndrome with diarrhea. Patient had a colon perforation and resection of colon in 2015, mixed hyperlipidemia and osteoporosis. So on the physical exam, there was a hipped up horseshoe-shaped lesion of the vertex scalp with a diameter of approximately 3 centimeters. There was no palpable lymphadenopathy, nor parotid masses. Here you can see the image of the lesion, which was seemed to be with 3 different focuses.
Tony, they used to run this tumor board where the discussants would ask the expert panelists and not the fellows. Is that still how this is running?
Yeah, that's right. And it really is, it's open for however you want to run it. There's no strict rule. But typically the faculty mentor might comment on a few components of the case, ask other faculty members, and then engage the senior discussants.
Great. So if Adam, great presentation. I just want to jump in for a second because this was really important when I saw this patient. Does anyone on the call have any immediate kind of questions about the pathology and about, does it kind of line up, does the advertisement line up with what you're seeing here?
No.
So why don't we, Ryan, tell me what you think, what you're thinking.
Yeah, I guess I'm wondering, where is the biopsy coming from in this representative picture? Because sometimes we get a biopsy and what we see meets what we expect. And to answer your question briefly, what you reported via the biopsy is not what I'm thinking I'm seeing here.
That's right. We were wondering that too, and it was a shave biopsy done outside, and we're thinking maybe from the midline of the lesion. We could not really tell where they took the biopsy from.
Yeah, I called the dermatologist and tried to get some pictures. It was really hard to get any information from them, honestly. So that's a great question. So, anyone have any questions about the T2B? Like what should that What should that mean?
Yeah, I mean, there's a lot of interesting things about this photo, right? I mean, one, there's a complete lack of pigmentation, but it's consistent. And two, it almost looks like that thing is totally discreet up above it, like it might be a satellite. And, it's one of those things where you're like, you want to kind of shave his head and see what's under there because it might be far more extensive than even we know so far.
Yeah, and I would just add that, I mean, obviously you don't really know the full thickness of this. It doesn't look 1 millimeter thick, at least portions of it. So that's a concern. Desmoplastic lesions in general are, the biopsies, it's hard to know what to biopsy. This one, it's pretty clear what you want to biopsy. It just doesn't seem like they've adequately sampled that.
Yeah, so I just wanted to add, this patient actually came in as a second opinion, and she was already on the schedule with a different surgeon for a wide excision and a sentinel node. So everyone's comments are great, and that's exactly what we were thinking. So Adam, why don't you kind of so first of all, and then T2B should be with ulceration, but they didn't talk about ulceration. So the whole report was kind of a mess. So let's
TJ, this is I missed that. It's a desmoplastic melanoma.
on the report they called it a desmoplastic, yes.
That's right, desmoplastic.
Okay, and that was not quantified, the amount of desmoplasia.
Yeah, they didn't say a mixed or a pure. They just it was a simple description.
I think it's a good teaching case too. Is like when I was a resident, I don't think I was taught to do like routine punch biopsies, and we use it as one of like most routine biopsies that we do in the office anytime somebody comes in and anytime there's a question.
And I would, going back to the presentation, I thought it was pathologically staged as T1B because of the 1 millimeter. And the obvious comment there is that you don't really have the full thickness assessed. So you certainly can't stage it as a 1B. But I think it was 1B. Am
Oh
I
yeah, I might have missed that. I might have confused it with a few other ones.
equally problematic? But anyway.
Yeah.
Other
Okay,
points,
so
other, yeah,
go ahead, Adam.
Other points of discussion is the clinical significance of desmoplastic melanoma, either mixed or pure desmoplastic, the value of the genetic testing in melanoma, and thoughts about shape biopsy versus incisional or punch biopsy for the panel.
And I saw that they get, oh, go ahead.
It's okay, go ahead.
I was just going to ask, how often do you guys yourselves order Castle, the Castle Bioscience testing? I sort of intermittently have it come in even on ones that are sort of smaller or early stage. I'm just curious how often you order it or how often you see it.
Yeah, I'm seeing it from outside fairly frequently. I don't really make much take a lot away from it. It's really understudied, and I think it's not validated. I don't order it myself.
I agree.
Here's the other comment I'll make with that is that you don't know what the training set is for this test. You don't know, for example, this is a rare subtype of melanoma. We don't know if this test is valuable for desmoplastic melanoma.
I agree. I mean, I think we do see frequent testing. So not just Castle, but sometimes we'll see Caris and other stuff. And sometimes that's as, valuable if you're getting readouts on the frequent mutations or the high or the mutations that are potentially targetable. But in an initial case, that's a little bit of a different story, how you would integrate it.
Yeah, I think it's tough when I have found that when patients come in with those, they already have sort of a preconceived notion of what to expect, and I think that that's one thing for the fellows when you're out there that you're going to have all sorts of people doing biopsies, and they're how comfortable they are and familiar with melanoma is going to be different because it's spread out between, obviously dermatology, plastics, general surgeons. So just one thing to take note of when they come in with that.
Yeah, one last comment too. Even if it was reliable, you got to think about how is it changing your management. And so at this point, I would never not do a sentinel node biopsy if there was a low risk readout on an intermediate thickness melanoma. And if I had a very thin melanoma with a very high risk gene expression profile, maybe that would, tip the balance, especially if a patient was particularly nervous. But that if you think about it, those are really the only two decision points that it's going to affect.
Moving forward, we repeated the biopsies. We did 3 different punch biopsies on the 3 areas that you can see in the image, and the result was a melanoma with atypical spindle cell proliferation, mixed desmoplastic type. The depth of invasion was 1.4 millimeters. There was no ulceration and no dermal mitotic figures. Positive for SOX10 pram, and negative for melan A and P40, 40, I'm sorry, and was staged as a PT2A, PN1, CM0, stage 3.
Yeah, and we got to go through the images because the PN1. So just to kind of go through my thought process, Dr. Curry was asking, it looked almost multifocal or it's different, like a satellite lesion. So that's why I felt it was important to biopsy all 3 sites. And in all 3 sites that were biopsied, there was no like epidermal component. It was all, even though there's only 1.4 depth that they measured, the entire every specimen was dermal extension. So we'll show some slides of that here.
Was
You can see
there,
that.
did you have a biopsy of that intervening? I can't really tell from the photograph. That intervening area almost looks like a skin graft, but obviously it's just his.
Yeah, in the middle. I didn't rebuy it. I assumed that was where they took the graft, and we asked for the slides a couple of times to be sent to us, and they never got sent. So, yeah, I mean, it's in that area does look like most of it looks like scars. So I'm assuming they shaved off the center of it. But even if that were it wouldn't have been contiguous with that number 1 biopsy, and probably not that number 3 biopsy, even if it was close to it.
You can see here the images and HME staining with deep dermal spread of the tumor. Here with a close up, and you can see how it's very deep spreaded, which is classic for a desmoplastic type. And the staining SOX10 positive and PRAME positive, but melan A negative.
The desmoplasia was good in the right hand side of your first slide, like all that eosin, like there, and then on the next slide too. But it's just a good example.
That's right. So further workup was done. The patient was claustrophobic, so he couldn't get a brain MRI, but a CT brain and neck was done. Didn't show any invasion intracranial or no invasion of the calvarium. There were no metastases, also in the CT chest, abdomen, and pelvis, and LDH was normal. So with this new staging.
If you could put up let's put up the picture itself and let's talk about treatment and poll the group. So, and sorry, Jessica, I'm taking over the moderator.
No.
Yeah.
Is that kind of know the case?
No, yeah. It's totally fine.
So, Dr. Gephardt, so seeing this, I guess, what would be the treatment options for, we have a mixed desmoplastic, you
So are
know,
these satellite lesions or thought to be contiguous with the primary?
I think it was very difficult to tell, but I was very fearful that these were satellite lesions. I mean, every biopsy we took
So
were
so
dermal,
the stage is CT1B. Was ulcerated? No.
not ulcerated.
So A, so sorry, B, and then CN1C, is that what we're calling this?
Yes.
Because these are satellites.
Yeah.
A couple thoughts about desmoplastic. This is not a pure desmoplastic melanoma, but these have proclivity or specific thing about two of them. One is that they're locally infiltrated. We see that on the slides that you showed. Two is that they have less incidence of regional metastasis. And three, we know newly that these are much more exquisitely sensitive to immune therapy. Um, Classically, we treated these with wide surgeries and adjuvant local radiation at least. But this is changing, and I like this case because I'm sure you're going to walk us through that.
Yeah. Yeah. Great. They also have high, uh, so, just to add on what you're saying, they have propensity to spread, with these kind of tendrils, away from the primary site so that you have to take a wide margin if you operate on them. And, they also have a proclivity for, perineural spread. Um, so, Dr. Weed, what do you think? Like, how would you approach this, surgically if you had to do it?
Well, the first thing I would say, just kind of to reinforce with fellows, this is exactly the kind of case that should be presented at a multidisciplinary cutaneous tumor board if you have that specialized tumor board, or head and neck tumor board if you don't. Because the to just say, okay, it's easily resectable, let's go ahead and do this, is not the approach to take based on the WISE biopsies that you have here. Um, the other thing about desmoplastic melanoma is, the data that we have on neoadjuvant immunotherapy. Ryan's comments are super important, but in terms of trial outcomes, desmoplastic melanoma is not going to be well represented in those trials. So just a little bit of a caution in terms of generalizing data, but this is a mixed type. So I think you have good arguments to consider this as any melanoma, and I think you need to talk about neoadjuvant immunotherapy before surgery for sure.
Sure.
Just one.
Yeah. Just go ahead. Who is it?
That was me. I was just gonna say, like, I know I mentioned it earlier, like shaving the head, but you cut this lady's hair, and you may find that there's far more. So you get to the OR, you if you didn't present the patient, you'd sort of be kicking yourself for sure. You could potentially find that this is far more extensive.
Yeah. Yeah, so we did present it at our multi-D tumor board. It was actually a little bit of a challenging discussion. I had to kind of convince people a little bit that, that I thought this was, a much more advanced lesion than it was advertised initially. Primary surgery for this is a 3 centimeter tumor at least, and then you're talking about 5-6 centimeter diameter defect on a fairly small lady. That's a big chunk of her scalp. And the her scalp is very taut. I don't think we would have been able to close her with eventually with a local regional flap. She probably would have needed a free flap. So we did talk about neoadjuvant approach. So Adam's going to present some data on that to kind of tie this up.
Exactly. So some studies looking at neoadjuvant therapy. We have the SWOG 1801 trial, which looked at neoadjuvant and plus adjuvant or just adjuvant therapy alone with pembro, and they did find that there was lower event. There was the probability of event-free survival was higher on the neoadjuvant plus adjuvant group compared to the adjuvant only group. And that was the initial, this was a phase 2 trial that started moving this, followed then by the NADINA trial, in which they looked at the combination of nivolumab plus ipilimumab as neoadjuvant, and then they would classify the patients depending on response to get adjuvant, different adjuvant or no adjuvant after surgery. And they also found that the neoadjuvant group did have better event-free survival. Looking specifically at desmoplastic type, we also have some data that supports that neoadjuvant, or in this case, PD-1 blockade, either with PD-1 or PD-1 ligand blockading therapy is effective at showing a tumor response in a significant number of patients. Looking also at the SWOG 1512 trial, where they looked at desmoplastic tumors and using neoadjuvant therapy. There was a single arm trial of 29 patients. They received pembro as a neoadjuvant before surgery for 3 weeks, and then after surgery they completed the therapy with pembro. And the primary endpoint of this study was pathological complete response, and was noted in 15 of 27. That's 56% of the patients. And none of the patients became inoperable, and there were no high grade 2 or more related adverse events in this study. So the patient was then started on pembro in a neoadjuvant setting due to his history of diarrhea. It was only pembro alone which was started for this patient. We're waiting for the therapy of this patient to show some effect or not, and if there is some good effect, we're planning surgical resection, possibly with reduction of the margins and sentinel lymph node biopsy. And then there's another point of discussion: would the panelists shrink their surgical margin if there is a response of tumor, or they would go to the former margins of the tumor?
That's definitely a tough call with desmoplastic, because your tendency is to take larger, although there's not great data to say that even wider margins are more effective. But Dr. Curry's point is a very important one. You need to understand exactly what you think the initial margins are, whatever your decision about resection. And if you haven't shaved that hair to really look at that closely, you may not know. So just a thought. But
the photos you took are really good too. I think that's another just sort of clinical thing, good photo documentation, just so you have some record along the way. Because in 8 weeks or whatever, when you take her, you may not remember exactly what it looked like. And if you had a good response, you might be in trouble. The appearance of that tumor histologically kind of makes you think of like sort of that WPOI5 pattern, right? Like, so discrete islands of tumor, which matches what you were showing on the photos too. So I mean, you get a good response, but you don't know, is that response in all areas with concentric shrinking? There are times when you can shrink your surgical resection bed, and that's one of the things that, of course, we look at in head and neck, but I don't know if I would routinely do it, or if I was worried about it, that I would do that.
And just to clarify, I wouldn't. I would resect what I would plan to resect. I might not try and go 3 centimeters or something even crazier for desmoplastic, but I would certainly resect what you showed there.
Yeah, I probably acknowledging that you may give this patient radiation afterwards because you're not going to know what the pathologic response is. That I probably would go a centimeter around all that, and I'd probably try to delay it, like you said, TJ, and rotate something. I don't know exactly where on the scalp that is, if there's muscle underneath it or what, but I'd be kind of hedging on that a little bit, not knowing what she's going to need afterwards or he.
Yeah,
When
this
you
whole, oh, go ahead. Who?
Oh, I was gonna say, when you guys have these sort of larger lesions, especially in the scalp with a draining pattern that is just quite broad and unpredictable, are you involved in the actual injection for the sentinel node, or do you just have the whoever's in nuke med perform it?
I do it.
You do it. And what's your technique for that in terms of the number of spots that you go around, especially for larger lesions?
I mean, that's a big one, right? But I mean, I usually ask for 4 needles. I don't know that I do a whole lot more than 4, but I try to get 4 quadrants. Would that be good enough for this person? Could you split it up? I don't know if anybody else has better techniques. Most of the sentinel nodes I'm doing are, honestly, I do a lot more like orbital and ocular stuff, but that's probably what I would do for this is 4.
Yeah, I think the scalp, our people pretty good at doing 4. I trust that is, for oral cavity and stuff like that, I'll do it myself. But for these, I'll generally rely on them. But it's not so much when they do map them, the tricky part is what if they map to both parotids and both occipital. Sometimes I do tell the patient if it's way too many areas, there's a small chance we would forego the needle by the sentinel node. But
If this were a pure desmoplastic, would that change your thinking?
yeah, I think
No, typically that is.
I probably still would do a sentinel node, but again, if it mapped to 5 different areas, I would be less inclined to go chase all of those in a pure desmoplastic. Um, the But yeah, it's thankfully I haven't had someone map to all of those locations in one time. So I have done like a parotid and an occipital, and which is kind of weird, but it happens, and you have to trust where the drainage is. Um, s- uh, I I don't want to belabor this case because we probably have 2 more cases. So we can probably move ahead. If that's anyone has any final comments or questions?
I think, this is Alice Lynn, I think if the final pathology did show significant amount of desmoplastic melanoma, I wouldn't hesitate to also send the patient for adjuvant radiation evaluation.
Sure. Yeah.
Yeah.
A real quick comment on these adaptive surgeries. We're learning more and more about it. There's no right answers, but it does seem that, especially for squame, that if patients have a CR, generally there's not these foci that are recurring. And the other comment for me for desmoplastic, their real survival issue is distant metastasis. So yes, I would definitely remove the lesion, the scar, but I wouldn't go too humongous if they've had a clinical complete response, because I can monitor that scalp, but if they haven't responded to the immunotherapy, I think her chance of distant mets is her probability is very high. If these are true satellite lesions, and it really, her survival is heavily dependent on the therapy she's already received. That's why I kind of push for her to get immunotherapy up front.
Yeah. And a local recurrence could be salvaged.
Yeah, your surgery is not what's ultimately kind of saving her life, I don't think. But
Any comments from our medical oncologist on this? We don't see desmoplastic as often as maybe these other 2 cases that we'll talk about, particularly with adjuvant immunotherapy now that she's had. Well, I guess we don't know yet what her response is. Is that correct? This is a in progress patient.
yeah, it is. I don't see Dr. Sanger on the call. I texted her.
Oh, sorry.
But But I do want to say on the Nadina trial, if you had a CR, they actually don't get adjuvant immunotherapy, which I
Right.
feel a little nervous about. But um, yeah, that's a difficult discussion if they have a complete response.
Thank you very much.
All right. I don't have the PowerPoint for the next one. I'm not sure if someone is able to share that.
Sure, who is it? We both have our PowerPoints, so we should be able to.
Oh, yeah. Yeah, if you want to share and please.
Oh, yeah, I wasn't sure if you had me next or if you.
Oh, no, that's perfectly fine. Yeah, yeah.
Okay. All right, here we go.
I guess while she's pulling that up, TJ, I was wondering about like order of operations. Like, would you ever do the sentinel node first, then do the neoadjuvant? I mean, you already kind of had your decision made by the staging on the primary, you know, the lesion that was the primary, but with the negative imaging in the nodes, and if you were on the fence, I was wondering maybe if tumor board they tried to push you to do it first or what.
Yeah, it's tricky because usually we're giving neoadjuvant people with positive nodes,
Yeah.
so that's why this was a challenge. But in this again, I wouldn't have done again. I think if they're gonna if they weren't gonna give her neoadjuvant, I guess maybe I'd consider that. But I don't I don't know if you're gonna be in that situation very often.
Yeah.
All right, we're good to go.
I'll confess, this is I saw Dave Cognetti on this is his case, but Harleen and I will go through it. I don't know if you did it, Harleen, but
Yeah, I actually was in the case, so thanks to Dr.
Okay.
Curry for his mentorship and thanks to Dr. Cognetti for the case. So we have AS. He's a 55-year-old man who presented with a draining left scalp lesion that was present for about 2.5 months. Past medical history, mostly notable for no history of any autoimmune disorders, no immunodeficiencies. He had no real oncologic history and no social risk factors. And he presented to our office with a shape biopsy that was positive for nodular melanoma. On physical exam, you can appreciate in the hair-bearing area, 1 centimeter scaly lesion of the left temporal scalp. Did have some surrounding erythema, and then of note, there was also a palpable left pretragal lymph node that measured about 1 centimeter. This was the pathology that we received, so you can appreciate the Breslow depth is at least 1.1 millimeters, Clark level is 4 at least. There's ulceration present. The mitotic rate's 10. The lesion extends to all margins, and primary path staging was a T2B. I can pause here, but in light of time, I can go on to imaging too, whatever everyone prefers.
what's that? I mean, I don't know if anybody has any questions about this. I guess
Yeah.
in this setting, you've got a node that's evident. Would you then rebiopsy this thing with a punch to get a full depth, or would that change what anybody does from here, or any more information you want on this patient?
I mean, I'm not sure I would rebiopsy the primary. I guess is there any chance you don't have regional nodal disease? It certainly doesn't seem like it. I haven't seen your imaging, but
Yeah.
be the only other question, I think.
It's a good question. We will get there.
Yeah, you'll see this at least thing a lot, and it's frustrating. If there's no node, in a lot of cases, I'll rebiopsy to try to get the true depth, especially if it's like 0.9 and you're thinking about a sentinel node. But it's a nodular. It might be a thick melanoma, so I would want to know that if it's 6, 7 millimeter depth, I would want to know that.
All right. Moving forward, imaging wise, we got an MRI and a PET CT. So here you can see the MRI is going to demonstrate several soft tissue nodules in the parotid gland and the left neck. I'll briefly show you the coronal. The left neck node was notably necrotic. And then they're measuring about 13 and 15 millimeters. And on our PET CT, you can appreciate the hypermetabolic left scalp lesion, multiple intraparotid lymph nodes that are hypermetabolic, and cervical lymph nodes, right? In 2A, and a smaller one in 4.
Real
We
quick,
did
that one parotid node that you just showed, that wasn't a deep node, was it?
superficial.
I've missed it.
That
but
one right there is the cervical node, the really bright one.
okay, got it.
You're
I just
referring
thought so.
to the one here.
Yeah, that's okay.
Yeah, I think
I
it was
caught
that
it quickly, but it's something to
Right.
think about.
Yep, for sure. So we did do an FNA of the palpable node in the parotid gland, which was positive for metastatic melanoma. There were some additional tests, notably BRAF, NGS, and ctDNA that we couldn't do due to lack of viable cells. So in summary, we have a stage T2B, N2B, stage 3 locally advanced melanoma of the left scalp. I'll pause
But
here.
before you go,
There are questions.
I mean,
sorry.
you had a little tell with your history of
Yeah.
autoimmune, but so I don't know. Does anybody have any thoughts on this in terms of next steps, approach, or other workup? Or I mean, are you routinely ordering PET? I don't know if anybody wants to comment on all this.
For these patients, yes to PET and yes to brain imaging.
And then management-wise, any
Don, you might be
thoughts?
muted.
Sorry,
We heard you.
I
Yeah,
agree
thank
with that. And if there's any question about the MRI, CT for sure of the brain.
Yeah.
One thing I would say though, just before you mentioned that you did your FNA, if those nodes were just limited to the parotid, I would, in an older man like this, I would absolutely make sure that no one lets you not biopsy one of those
Yeah.
nodes, because that could be a Warthin's tumor in
Mhm.
somebody with a melanoma that doesn't otherwise need neoadjuvant immunotherapy.
Good point. All right, moving forward, kind of spilled the beans already, but we decided on neoadjuvant treatment for this gentleman. Adam already did a great job of introducing the Nadina trial, but just in short, this is an international phase 3 randomized study. They included 423 previously untreated patients with stage 3 macroscopic resectable melanoma with at least one positive lymph node. They were looking at event-free survival in the neoadjuvant group, which they got IPI and Nivo versus adjuvant Nivo. So our gentleman, following his treatment, did experience a decrease in the size of his primary lesion. I unfortunately don't have a photo of that. The side effects he did experience were pruritus and fatigue. And then we did repeat cross-sectional imaging, which showed us a reduction in the size of the lymphadenopathy. I have his PET here. You can now appreciate all the previously described hypermetabolic nodes are now smaller with lower intensity. There are some new small active nodes bilaterally, which were thought to be inflammatory changes related to the immunotherapy.
I guess that's a good clinical point. You know, if you think you're going to get a PET after immuno, it's good to have a PET for immuno. Because frequently you'll see other nodes light up, mediastinal nodes or other things, which, you know, could be a good sign or a bad sign, but the baseline comparison becomes important.
Yeah, no step.
So what's the extent of surgery all the surgeons would recommend in this case?
Do you want everyone to
Well,
comment or?
Yeah, I mean, I'll chime in that, you know, until we have so you're considering uh, that PET scan just tell me again what your sense of response radiographically was? Remind me.
Partial response.
Partial. I mean, I think he needs wide excision of the primary parotid on that side, and at least a 2 through 4 neck. It looks like that's where your adenopathy was. I don't think you can do less than that yet, although the data is probably around the corner that had you highlighted your index node, you could do just a node biopsy before doing complete neck dissection. Again, not there yet. Small trials have shown that that's safe, but the larger trial is in the works.
Yeah, this is why like when I only taught a cursory glance at that PET, I was asking if that node was a deep lobe parotid node or not, because that would definitely, perhaps not be in your resection plan, and you definitely would want that in your resection plan. I think the Nadina trial, they actually put a little seed in all the positive nodes to ensure, as a quality measure that those were resected. So if you have a complete response, it can be challenging to really be sure that you got out the nodes that were originally involved with disease. But yeah, but I agree for this. I would do, a wide excision of the primary site, and I would do a parotidectomy neck dissection, including all those levels.
If this patient originally only had parotid mets and no neck adenopathy on the surgery, would you consider the neck dissection or just do a parotid?
That's a
I
great
don't know
question.
if I have a good answer for you, but what I would generally do is try to be like one level further than anything clinical. So I think I would probably make sure that I address the EJ nodes, because I would think of that as like the next chain. Maybe if there was just one node, a complete parotid would probably be good. So maybe you don't need to go that far much further. But I think with more than one parotid node, I think I'd want to know that the next chain was clean.
That thing that is being discussed as a deep lobe parotid is a high external jugular node, and those have to be removed in this. It's commonly stated as a parotid node, but it's actually just behind the tail of the parotid. And I agree with what everybody else has said about extent.
Yeah, that's a great point with the skin cancers. You got to remove those EJ nodes. Yeah, I get, I can hear Randy Weber's voice in my head when I do these cases, because back then for anyone with positive nodes, he would do a modified radical for all of those, because melanoma can have a pretty strange pattern of spread, not our typical aerodigestive, and so often we would be doing level 5s even for those. But in the setting of neoadjuvant therapy, I agree with Joe. Like, we don't know, what the true resection has to be. I think, to answer your question, Jessica, with the parotidectomy, with the parotid node, I would do a parotid and probably do level 2, maybe slide down into 3 and like get one around. And again, I think the thinking behind that too is, your surgery is not ultimately probably their life-changing thing. It's really their risk of distant mets that's going to be their problem. So their response to immunotherapy is really important. The only comment about the Nadina trial is the outcome was event-free survival. It wasn't overall survival. So again, we still don't have really mature data, even though those neoadjuvant curves look so fantastic. We don't know the long-term differences, and this all is related to this discussion. Like, we don't know if any of these things are really impacting, even the extent of our neck dissection, if that's going to impact their long-term outcomes.
They do look good though.
No, I know it's promising, but it's really just their time
Yeah,
to their
you're right.
melanoma coming
You're right.
back.
OS is going to be the goal.
Harleen, I think this is a great case, and I think all the comments and questions are really great. I work at Kaiser, it's a big managed care program, so we know our patients aren't generally on clinical trials, so we follow NCCN guidelines very closely. And the guideline is after neoadjuvant to do a therapeutic neck dissection. But looking at the PET, you mentioned that they thought that some of the lymph nodes were from an effective immunotherapy, and although we all learned about pseudoprogression with immunotherapy, or like every immunotherapy paper just talks about pseudoprogression, but I actually haven't actually seen it that much in clinical practice. Whereas, meaning like there is activity or increased activity in lymph node. Often I remove the lymph node, it has cancer in it. I don't see that much pseudoprogression, meaning the PET shows activity and ends up being just benign. So I think that's something I learned in my practice in the last few years.
A handful of people didn't get surgery in that trial, and it was something like less than 3%. I don't know, TJ, it was like less than 3% that progressed and had true hyperprogression and were no longer surgical candidates. So, I mean, it's another thing we think about, right? Like, so it's the importance of the trial is not just the outcome, but the safety, right? I mean, people can die from immunotherapy. Fortunately, it's very rare, but it can happen. It's real. On this trial, actually, one patient did die in the
Yeah, I mean, I just had a patient who had a myocarditis and
yeah.
had a cardiac arrest one day after getting immunotherapy. It's crazy. It does happen.
Yeah.
Just to comment on the pseudo progression, that specifically is often referring to their first cycle and having the tumor expand after the first cycle. So I just want to clarify that when they talk about pseudoprogression, that's usually referring to that kind of false progression of the tumor after that first infusion.
Yeah.
But I have had a patient hyper progress too, and we kind of delayed watching them to the second cycle, but his tumor was just exploding, and so you do have to be worried about missing that when you're thinking it's just pseudo progression.
Yeah, I think my point is like yours, that you can't just count it to be like pseudoprogression or immunotherapy reaction.
Yeah.
I would remove every lymph node that had activity on the PET.
I would just add to this really interesting discussion is that while we're talking about being more rather than less complete with regard to regional nodal disease, I think we're going to have more data sooner well, not sooner. It's going to take a while for trials to mature, but index lymph node resection to assess response and then determine whether or not there's going to be any further dissection, similar to positive sentinel node, not necessarily completing neck dissection. The Prado trial is too small, but suggests that that's safe to do. MSLT3 will answer that if that gets going. So yeah, but the head and neck specifically, if your sentinel node or index lymph node is in the parotid, it would be, you're not going to do less than a reasonable dissection because you're not going to want to go back to the parotid. So there are head and neck considerations that are really kind of distinct from these practice-changing trials that we always have to keep in mind too.
Great, really salient points. I know we're running a little short on time, but I will just go forward with the rest of the case here. So we did undergo surgery, and as everybody correctly stated, we did a wide local excision, a left superficial parotid, and a left neck dissection on this gentleman. His reconstruction was done by our plastics colleagues with a cervicofacial advancement flap. And for our final pathology, he actually had a complete pathologic response. So we only had evidence of an intradermal melanotic nevus with ciliary elastosis on the main lesion. All of the nodes were negative per tumor board discussion, and then in a trial, no adjuvant therapy was recommended, and he is on surveillance. The surveillance is dictated by a med onc who is going to be doing Q3-month PET CTs and yearly brain MRI. Of note, postoperatively, the patient was admitted for nausea, vomiting, diarrhea, and ended up being secondary to adrenal insufficiency, which he's still dealing with, secondary to the immunotherapy. So just an important point to discuss. And endocrine is recommended a stress dose of steroids for this patient anytime he's undergoing an acute illness, surgery, or hospitalization.
Did I miss? Did they get adjuvant immunotherapy though? No.
No, he did not.
Yeah.
Because of the complete response.
Yeah, crazy. I want to make a comment that you have to add this to your consent that you're going to do surgery and there's a possibility you do not find any tumor. 'cause that's a kind of a new thing we're saying a lot to patients, and that's kind of a crazy thing to consider when you look at this surgery. And
I just tell them that's their best path report. That's what we get.
yeah, that's true.
Good news.
Yeah, I mean, but I've done like a resected a part of a lip and done an AB, but then for no disease. So that's you have to really counsel them that you really these are important decisions and that there's a possibility there's no cancer there.
100%.
I'd say like you brought up another really good point, which is the adjuvant immuno, and that's one of the things I kind of like about this design is like you don't have to get it, which is maybe a little not the best for the drug company, but it certainly would be great if you're a patient and it pans out, right? I mean, if the long-term data is good, it's a very good thing.
I got three brief comments. One, if you're going to do an advancement flap for melanoma at the same time, be careful with that. Even if you think you had a complete response of the primary, you can get burned. Two is that with these pathology reports, there is a synoptic way to report these after immune therapy that's standardized. The pathologist, I can't remember the name of it, but they should quantify four things. Gil, please correct me if I'm wrong. There's fibrosis, there's melanosis, there is necrosis. What's the fourth one? Anyways, these should be so when there's no tumor in the specimen, they should say, hey, this is what we see there. For melanoma, they will see evidence that there was a melanoma there. It's just all dead. Okay. That may not be the case for squame where it's just fibrotic. And as TJ said, that can be distressing.
Are you talking about viable tumor for the other one?
Yes, sir.
Yeah.
The last thing is that these immune-related adverse events, endocrinopathies, that will be permanent, very likely, this adrenal insufficiency. And that sucks.
Hey, Ryan, thanks for the comments. Just to add some clarification, not only did the pathologist report those things, so there was melanophages and necrosis in 3 of the lymph nodes. The lymph node, the preauricular lymph node, which started off palpable, was pigmented. So when we opened them up, it was still pigmented. So the melanocytes are just in the macrophages.
Yeah. So that's often, I remember the first, very often this is what it is. And it's distressing because you think, oh no, the PET CT looked like a good response. And then there can be black lymph nodes everywhere and it's all dead.
There's also a phenomenon called melanin incontinence, which is sometimes there's just melanin in the lymph node, which I thought I got fooled by that. I thought it was the best term ever from a pathologist, but it's just pigment in the node from the tumor being broken down.
Are you sure your pathologist wasn't just jerking your chain?
She might have been. She's pretty clever.
That's all I got for everyone, so I will stop sharing so we can get to the last case.
Thanks so much. I'll see.
Feel free to modify, Gil.
Yes, absolutely, I will. And thank you, JJ, for saying that it's okay if we go a little over, but I'm going to try to keep that over as low as possible. So I'm Gil Towns. I'm one of the head and neck fellows at MD Anderson, and I am also presenting a case of melanoma with regional metastasis. So it seems like we all had the same idea today. But so we had a 77-year-old gentleman who presented with a posterior scalp melanoma a posterior scalp lesion that he first noticed 4 months ago. You can see it pictured there. The biopsy that he came from the outside with showed unclassified invasive melanoma, Clark level at least 4, thickness at least 1.4 millimeters, ulcerated. So, and then he also had a palpable lymph node in the right supraclavicular region. I'll just blaze through this. So past medical history relevant stuff. He had a history of corneal transplant and splenectomy. And he underwent an FNA of that supraclavicular node, which did show metastatic melanoma. So he ended up getting a PET scan and an MRI of the brain. The PET revealed the FDG avid lesion in the posterior scalp and 2 avid right neck lymph nodes. He had no evidence of distant metastasis. So he was also stage T2B, N2B, M0, stage 3B. So he was presented at the multidisciplinary melanoma tumor board. This is his mutation profile here that you see on the slide. So there were several options given to him, like the previous cases we discussed. It was recommended that he have neoadjuvant immunotherapy, and the options are single agent immunotherapy or combination immunotherapy. And then there's also the targeted therapy because he has the BRAF V600K mutation. Previous 2 cases already went over the Nadina trial. There's been a phase 2 trial that we've participated in with a different combination, which is nivolumab and relatlimab, which is Opdualag is the brand name for that, which has shown very similar response rate and event-free survival to the Ipi-Nivo combination, and in our data has shown less toxicity events. So that's what we recommended to him, the tumor board recommended to him. And the typical way the typical course for that at MD Anderson is they get 2 treatments 4 weeks apart. So he underwent 1 treatment, and then 4 weeks later he came back. They drew labs. He did have slightly elevated liver enzymes, but they were still within parameters to give him the second dose. So they went ahead and did that, gave him his second dose with a checkup in 2 weeks after that. At the next checkup, he did have significantly elevated liver enzymes. So that's a note that one of the toxicities that comes from this is, or actually the most common toxicity from this treatment is elevated liver or transaminases. So the plan was always to get 2 treatments and then undergo surgery, which he did. I meant to talk about his history of splenectomy was discussed, but not considered to be a contraindication for immunotherapy. And the same with his corneal transplant. He was evaluated by an ophthalmologist who recommended that we go ahead. It was not going to be at higher risk. And if there was a complication with the corneal transplant, it was not considered prohibitive to repeat the procedure. So this was what he ended up getting. After his 2 treatments, he had the toxicity that I talked about, and he was noted to have progression. The physical exam, the lesion grew, and his restaging PET, which is part of the standard treatment for these patients as well, showed progression of his local regional disease. So he went on to his planned surgery, which was, even though he had the toxicity, that actually did not change the surgical plan because he got the 2 doses already, and he underwent a wide local excision of that scalp lesion with 2-centimeter margins to a depth that included the fascia of the muscle. He was reconstructed with a full thickness skin graft harvested from his neck dissection incision, and he underwent a level 2 to 5 neck dissection. Should I stop here? Do anybody have any comments so far? I know I kind of went through this really fast. I was trying to get us to this point.
Yeah. Was it 5 or did you do a formal posterolateral neck dissection?
Formal posterolateral.
Okay. Yeah, it's just important to note. I mean, obviously, especially in where that location is, you have to include the occipital, suboccipital nodes, retroauricular nodes, and the original description was you're supposed to take part of the trapezius, but you don't really do that anymore. But you got to get way back there beyond level 5 and get those nodes out.
And when you noted the progression of the regional disease, what type progression of the ones there of new nodes that had
Just increased size of the ones that were already noted. And there was no distant metastasis on the restaging PET.
Did your primary progress too?
It did increase in size, the primary.
Did you have to reconstruct that, or did you just skin graft them?
It was reconstructed with a full thickness skin graft. Yeah, just skin graft at the time. Yeah. So his pathology, this report is a little bit. Go ahead.
So sorry to interrupt. Just as a question for others, in terms of these sites that feasibly could be, not immediately reconstructed, does anyone do a delayed recon to confirm margins?
Yeah, I would always delay, as Dr. Gephardt brought up, I always delay a reconstruction for melanoma because you can't assess the margins on frozen section, and you don't want to move around your margins before you know they're negative.
This is also a good option for an Integra or something like that potentially can granulate in over time. You don't necessarily even have to do anything else, but you haven't cost the patient anything by putting it on there.
Yeah, the thing is, like, I don't worry too much about like bringing hair-bearing tissue to those areas because you're going to radiate it anyway, and they're going to lose a lot of hair. So getting them through their treatment, if you think you're going to radiate, I should say, but getting them through their treatment is going to be the biggest thing.
Yeah, the Integra grafts, I really like those. They are also expensive. We have to think about that. I think the smallest one is maybe $5,000.
Thank you. So this is a good example of what we were talking about with the first case, how the depth was 1.4 millimeters with a shave biopsy from the outside, and then on the surgical pathology, it was 13.4 millimeters depth, Quark level 5, ulceration present, and there was microscopic satellitosis. The neck report got mislabeled, and there's a pending correction to that, but the levels are switched. But so you see that there's 4 lymph nodes were positive with metastatic melanoma with focal therapy effect. But importantly, here you see that there was 70% viable tumor with 10% necrosis, 10% pigmented macrophages, and 10% fibrosis. So basically, this classifies him as a non-responder to immunotherapy. So I guess the question now that I was going to ask the panel is what do you do in these cases where you have a non-responder to immunotherapy, and what are the options for therapy adjuvant?
Again, multidisciplinary cutaneous tumor board. I mean, it's the tumor board where we have kind of monthly changes to practice, and having a medical oncologist who is cutaneous malignancy focused is a huge asset. I think discussion about targeted therapy would certainly be appropriate, as would radiation. Those would be the questions I would be asking my medical oncologist personally, since she's BRAF positive, I think you said.
Yeah,
Yes, V600K.
I don't think they're using targeted therapy in an adjuvant setting. Am I wrong about that? I'm sorry, our medical oncologist isn't on, but
So there is an adjuvant BRAF targeted therapy trial. So it can be
trial, but
yeah.
it
No,
hasn't.
it did show positive results. So it can be given adjuvant.
Okay. Because I guess the only other thing too, because they got the LAG-3 inhibitor,
Yeah, exactly.
they haven't seen CTLA-4. So again, I don't know if they would do the ipi-nivo in an adjuvant setting, but if if they were treating distant metastatic disease and it progressed on like Pembro alone or Nivo, you know, they might, I think they might try it being Nivo. But
Yeah, I'm sorry I went through the presentation so fast that I didn't dwell much, but he did also have a toxicity with elevated transaminases with immunotherapy, so that's another consideration for him too.
I guess would anyone for this high risk patient consider adjuvant radiation? If
Yeah, I mean, this is my patient, but my concerns were, you know, classically we used to do surgery followed by radiation. We didn't have a good systemic therapy. And there was, you know, our data, I think, is 90 or 91% regional control rate. That did not impact at all the melanoma specific survival. So what we're trying to change in this guy who has a super high risk for distant metastasis is that, and it didn't respond. Now we're falling back, and I'm worried, hey, you know, he's got satellitosis around this primary, nothing that could be seen. It was micro. He has some indications for radiation in the neck with multiple nodes, with lots of viable tumor. I mean, my vote for this is to give him radiation. I'll tell you that the medical oncologists weren't so excited about that, in part because they want to get him on systemic targeted therapy. There's some toxicity on that and delay for that if you give, you know, these BRAF MEK inhibitors. So, you know, that was kind of our discussion. The patient's just about 3 weeks post-op, I think.
Yeah, I mean, I think that's exactly the conversation, and I don't think there's a right answer. Your point is well taken. I think radiation is likely to improve his local regional control, but it's, you know, is it going to be targeted therapy that improves his survival? Again, we still don't even know that really for this specific patient, but if anything will, it would be that. So, both corners in the boxing ring have pretty good arguments.
Well, unless anybody has any other comments, thank you so much. Sorry, I had to kind of rush through that.
Nice job, Gil.
I just really wanted to thank anyone. That was a really wholesome discussion. IO is really taken over in the adjuvant, neoadjuvant. It's really becoming a big deal. And as Don Weed mentioned, it's changing weekly, monthly. So it's almost hard to keep up with all of the studies. I wanted to thank Dr. Yasensky for organizing, and all of our discussants, panelists, the fellows, the faculty, the mentors. Really appreciate you all coming out and doing this tonight. The next CDMS Tumor Board is on May 7th, same time, same place. It'll be on laryngeal cancer and partial laryngeal surgery. It'll prove to be a very unique and interesting session with some excellent discussants. And we look forward to seeing y'all then.
yeah, thanks to Alice Lynn, because she was really instrumental in putting this together. And this is
All right.
always a lot of fun. Thanks everybody.
Yeah.
Thank you,
guys.
Alex.
Thank you.
Thanks,
Great
Great job to all the
Thanks
fellows.
for the invitation, Alice.